hamstring, and glute max.
بعمل validation.
Ask the patient to lift their leg off the table, feeling for muscle activation, as well as observing movement pattern. As seen here, the patient's knee is flexed, as well as I felt hamstrings turn on prior to glute max. Normally, the hamstring and glute max should fire together, followed by contralateral, then ipsilateral paraspinals. This can be followed up by passively taking the patient's hip into extension while palpating the glute max, and then asking the patient to hold this position, feeling for muscle activation, as well as noting the movement pattern. Again, you see the patient's knee flexes, and I felt a delay in the glute max muscle activation. This can be trained by using a quick stretch to the glute max, by letting the femur fall down towards the table, as well as a tactile facilitation with tapping or rubbing. This should be repeated multiple times, asking the patient to then hold, feeling for an improvement in the glute max firing. Again, and hold. Once activation has been improved, reassess the patient's hip extension movement, palpating the muscles, looking for the ability to keep the knee straight and the glute max to fire as soon as the patient lifts the leg off the table.
يعني هو بيعملها عشان الهامسترنج متشتغلش مع الجلوتيوس ماكسيمس.
With the patient lying sideline and the involved leg up, place the trunk and pelvis in a neutral position. Passively take the leg into an extended position where it's in line with the body. Palpate the quadratus lumborum, the glute med, and the hamstring muscles. Ask the patient to abduct their leg into the air, watching for the movement pattern as well as feeling for muscle activation. As seen here, the knee flexes and hamstring tone was felt prior to glute med activation. You can then passively take the legs into the air, use your thumb to palpate the muscle, and ask the patient to hold this position. Again, the same movement fault is seen as the knee flexes, and the glute med was not felt under my finger to turn on properly. You can then support the knee in your arm and with your hand while allowing the muscle to be quick stretched by dropping the leg down. A tactile cue can also be added to the glute med muscle at the same time to try to improve activation. Ask the patient to then hold this position to feel for improved activation. Repeat multiple times until improvement is felt. Once the glute med has improved activation, then retest the sideline hip abduction with palpation of the muscles and observe for an improved movement pattern, not seeing the knee flex in this position.